Welcome, everybody, to Cases from the Community, investigators discussing available research guiding the care of patients with ovarian cancer. Thank you all so much for joining us. I'm Joyce Liu. You might notice that I do not look like Dr. Love. I have the privilege of being the moderator today, together with the rest of our faculty, Dr. Mirza, Dr. Oza, and Dr. Penson. So thank you very much for joining us. For people looking for the seats, there are plenty of tables sort of up in the front. I know everybody likes to come up to the front with us. These are our disclosures. This is our agenda. This is broken up into 4 modules. Each of the modules will have 2 components. One will be a series of cases with some questions for our faculty, and then followed by a short didactic from our faculty members. These are some of our participating physicians who have submitted cases, and we thank them for joining us as well and helping to contribute to this program. You'll hear from them by video with the cases that they have and the questions they have for us. All right, so we're going to start with Module 1, Optimal Genomic Evaluation of and Targeted Therapies for Newly Diagnosed Advanced Ovarian Cancer. So this will start with a case presentation from Dr. Willmott.
Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library, today featuring patients with ovarian cancer. We met with a number of community-based gynecologic oncologists and gathered current cases from their practices, beginning with Dr. Lyndsay Willmott, who asked about a 44-year-old morbidly obese woman with a BMI of 70, also of the Jehovah's Witness faith, and with ovarian cancer and a germline BRCA2 mutation.
She presented with ascites, pleural effusion, and carcinomatosis, and she underwent an IR-guided biopsy to confirm diagnosis, which revealed high-grade serous carcinoma suspected to be of ovarian origin. Because of her disease burden and her habitus, along with her faith, she was counseled that she was not a good candidate for an attempted and upfront surgery. So she was instead started on neoadjuvant therapy. Because this patient had very severe ascites and pleural effusion, I counseled her on adding in bevacizumab to her cytotoxic platinum doublet. So she had also undergone genetic testing, which revealed a germline BRCA2 mutation. So I talked to her about the PAOLA-1 regimen with bevacizumab plus olaparib. And so she's now been started on that, and so far she is doing well. My biggest questions are, for patients who aren't candidates for surgery, what sort of treatments you recommend for them? What sort of threshold do you have to decide who could be a candidate for surgery at baseline? For really ill patients for whom surgery may be risky?
So, faculty, in summary, Dr. Willmott is interested in your approach to patients with ovarian cancer who are not candidates for surgery and how you make that determination. This case also brings up the question of optimal maintenance treatment in patients with BRCA-somatic or germline mutations, including the choice of PARP inhibitor, the duration of treatment, and the role of bevacizumab.
So in a somewhat unusual situation for the SGO meeting, you have 4 medical oncologists up here, so we won't presume to tell you how we make the decision about whether somebody's a candidate from surgery outside of calling one of our surgical colleagues. But I do want to ask our faculty here, Dr. Penson, when you have a patient who is not a candidate for surgery, how do you think about treatment for them?
Yeah, so that take home, have a great surgical colleague is really important. You have to remember that up to 10% of patients presenting with ovarian cancer are going to have treatment refractory disease. And you've got to pick out those, and they are typically identified by a failure of the CA125 to respond. So 3 cycles of neoadjuvant chemotherapy, more than half of our patients at MGH get neoadjuvant chemotherapy. And if that CA125 gets stuck, you really have to get a CAT scan and reconsider the merits of surgery.
Great. And Dr. Oza, what is the optimal PARP inhibitor do you think about for primary maintenance therapy for these patients?
So in terms of the evidence, the evidence related to the combination with bevacizumab has been really generated with olaparib and the PAOLA data. And so I think the approach in terms of integrating bevacizumab in conjunction with the chemotherapy, I think, is a very appropriate one in this setting. And in this setting, I think that the options in terms of combining with bevacizumab would be to sort of look at olaparib following completion of primary chemotherapy and concurrent bevacizumab. Bevacizumab would continue for about 12 months beyond the chemotherapy, and the olaparib would be started at the end of chemotherapy and continued for a period of about 2 years. Having said that, in terms of the optimal PARP inhibitor, to be honest, it's really hard to say that there's an optimal one in terms of bevacizumab versus niraparib. The combinations and the evidence from some of the other studies suggest that the synergy between niraparib and bevacizumab would probably also be an effective choice in this setting. But the evidence has been garnered from the PAOLA study, which is with olaparib.
Thank you so much. And Dr. Mirza, you've done a lot of work combining bevacizumab or anti-angiogenics with PARP inhibitors. What do you think is the role of bevacizumab here in somebody with a BRCA-mutated ovarian cancer, and is it adding to PARP inhibitor alone?
So, thank you. First of all, I completely agree with what is said, and I completely agree the treatment which is being given by Dr. Willmott. Yeah. First, a patient had a bulky disease. We would always add bevacizumab to start with because of getting a better response, an early response, and fast symptom control. And I would go after evidence, and the best evidence we have is from the PAOLA trial, and exactly add olaparib on that. The evidence on the other PARP inhibitors is not level 1. Of course, if patient cannot tolerate olaparib for some reason, you can reconsider it and switch to niraparib in that case. But my first choice will be exactly what is suggested. I think the effect of the two is more additive than it is synergistic. We did the Vanova trial, and if you look at all these data, it probably looks like we are having additive effect and not the synergistic effect.
Yeah, all right. So those are some great responses. We're going to head to the next case.
The next case was presented by Dr. Kellie Schneider, a 53-year-old woman with BRCA-negative HR-proficient disease.
She presented with a large pleural effusion. Imaging further showed ascites, inguinal axillary lymphadenopathy. We did ask for the lymph node to be biopsied, and it showed high-grade serous ovarian cancer. The two images that we have show us this large right pleural effusion. You can see she almost has her right side completely obliterated with mediastinal shift. And in the pelvis, significant amount of ascites, large bilateral pelvic masses. She was debulked to an R0, and we restarted chemotherapy afterwards. And at the completion, she was NED chemically and radiographically. So my question for the group is, what do you use in this scenario? We did bevacizumab and niraparib maintenance. 18 months later, she is off the bevacizumab and is just on the niraparib, and she is still without evidence of disease. I can see some people in that scenario that would either use bevacizumab alone or niraparib alone.
Dr. Schneider is curious about the faculty's approach to patients with extensive intra-abdominal disease and pleural effusions, but with an HR-proficient tumor, and the potential use of the combination of bevacizumab and niraparib as maintenance. This case also brings up the issue of management of patients with genomic alterations other than BRCA, for example, PALB2, CHEK2, or ATM.
All right. So some really good questions there. Dr. Oza, tell me about, what do you think about the approach for patients with HR-proficient disease who have such extensive intra-abdominal pleural effusions?
So I think I'd like to congratulate Dr. Schneider for actually presenting us with a case which is a perfect clinical conundrum. So in terms of the setting, this is a really, really challenging situation, and the evidence really is challenging us in terms of what the next steps of investigation should be. First of all, in terms of the approach in a patient who has advanced disease, massive pleural effusions, and very bulky disease, I agree with the approach of actually using bevacizumab in conjunction with chemotherapy. I think that that's a very appropriate approach. In terms of HRD proficiency, the PAOLA study suggested that there wasn't the benefit in terms of continuing olaparib in a setting of patients who have HRD. Having said that, there is a little bit of a sort of a challenge in terms of really trying to figure out whether there is any potential benefit from niraparib, because of the PRIMA study suggested that patients who have advanced ovarian cancer would benefit irrespective of HRD status. So this is one of the questions that's really going to challenge us in terms of patients who have exactly this type of disease, if there is any additional benefit or not. But based on the PAOLA study, the initial evidence would suggest that the combination would not really benefit from adding in a PARP inhibitor. So I think continuing with the bevacizumab until completion of maintenance treatment would be the strategy. But the future question does need to be asked. If you have to choose between bevacizumab or a PARP inhibitor like niraparib, which provides perhaps a greater degree of benefit in patients who are HR proficient. And I think that that's really the next generation of studies that's actually going to be done, because I think that we don't have perfect evidence, but the approach that she took, I think, is very, very appropriate in this setting.
Okay. Dr. Penson, when you see these patients, we talk about BRCA testing. Do you test for other mutations? How are you doing your molecular testing for the upfront patients?
Yes, we've really shifted from germline to tissue testing, and the MGH panel is now 550 genes. So we absolutely are looking for these. And our education is improving. So BRIT1 might be added, but BARD would not be added. And so the sort of quality of our information is getting better and better. The first patient, you might, with like primary therapy, you might treat them indefinitely. But I think the big question is when you stop, because you do get a benefit, but only marginal benefit for a longer duration of bevacizumab therapy.
And excuse me, Dr. Mirza, when you think about people who have BRCA alterations or alterations that aren't BRCA, so PALB2, CHEK2, ATM, BRIP1, RAD51CD, are you treating them? How do you make a decision whether you're going to use a PARP?
Well, I completely agree what Dr. Raza just said. I think we will, first of all, in Denmark, we will not have possibility to treat patient with combination because that's out of label and we are not allowed that. Having said that, we would treat this patient with one or the other maintenance therapy, and she needs it. And I actually agree with Dr. Schneider to start with bevacizumab because of the burden. And I would have continued that patient on bevacizumab and save PARP inhibitor for relapse. The data we have, you can use that in US from Ovarian, but one should remember that is non-randomized data. We don't have a randomized data, and we have we do have randomized data from PAOLA, which does not show benefit. Having said that, this is a very difficult. We get the HRD testing done, and we get all these tumor mutations checked. And if patient, and that's where we go away from our label and are allowed to treat patients. If patients have some of the other genes and HRD score is not extremely low, under 42, we usually try to get that patient on a PARP inhibitor. But here I will continue with bevacizumab.
Okay. Great, thank you so much. All right, you're up, Dr. Mirza, for your didactic.
Okay, thank you very much. I have 8 minutes and 2 seconds. I got 2 seconds extra. And you have seen this slide very much. And as we just discussed, that it's just not the BRCA mutation, which is about 25% to 30% of the patients. We do have other 25% of the patients which have other abnormalities, gene deleterious mutations, which behave like BRCA. And HRD test, what we have today of different types, are trying to tease out these patients. None of these HRD tests are optimal, and we are working to get better tests what are available. I'm asked to talk about what data we have on the clinical data we have on the first line, and these are the 5 phase 3 trials which has been until yet presented. We have one phase 2 trial, Ovarian, which I've not taken in my talk here. If I take the first 3 trials, which were the basis for getting approvals, these are the SOLO-1, PAOLA-1, and PRIMA. I am told that I should not make any comparisons between the trials after 2019, but it is important to see what they are doing. It's not a comparison, it's just to say each trial breakdown with the molecular classification, how they are performing. And you can see all 3 trials when it comes to the BRCA mutation. There is a very clear benefit of giving, in the BRCA mute population, giving olaparib alone or niraparib alone, or the combination of olaparib with bevacizumab. When we come to you go down to the pie, to those 25% of the patients who are HR deficient but BRCA wild type, there we have 2 trials. SOLO-1 was not part of it, and one is PAOLA-1 and one is PRIMA, and both are positive, and it shows that you can either treat these patients with olaparib plus bevacizumab or niraparib alone. So you have 2 options here as well available. When we come to the BRCA wild type HR proficient disease, as Dr. Raza also mentioned, there is no evidence of benefit of adding olaparib to bevacizumab against bevacizumab in the PAOLA-1 trial. There is a modest efficacy of niraparib, but important modest efficacy. If you look at the curves, they are separated all the way till the data cutoff. And now we have also 4 years data on that as well. So I think we have this scenario and there is initial evidence from a phase 2 trial of niraparib plus bevacizumab showing benefit, but there is no comparator there, so it's difficult to say. And that's why we have approval of these drugs in the BRCA mute population. All 3 options are available, and when it comes to the HR deficient disease, BRCA mute or BRCA wild type, you have 2 options available, either niraparib alone or combination of olaparib plus bevacizumab. When it comes to the whole population, then niraparib is available in whole population. Now we have long-term data of these trials, and here you see the Paul Di Silvestro last year presented the data, this year actually, presented the data on SOLO-1. It was last year in ESMO and published this year. And this is amazing that you see that even though the trial is not have reached its maturity, but it's extremely positive also for overall survival with a hazard ratio of 0.55. And when you look at the data on PAOLA-1, if you look at the whole intention to treat population, which half of these patients are HR proficient, where you don't see the benefit, then you don't see any benefit. But when you break down them again in the molecular classification of BRCA mute, BRCA wild type, but HRD positive or HRD negative, you can see the first 2, these curves are separating and showing benefit of giving combination therapy against bevacizumab. So I think these are the evidence, and when we come to the PRIMA trial, we still are waiting for events for overall survival. So the only thing we have right now is the long-term PFS benefit, and you can see these curves are nicely separated all the way till the data cutoff of 4 years here. So we hope that we will see overall survival in the same way as we have seen the other 2 trials. Then we have, and when you break down the PRIMA trial into the 3 again, you see the same pattern, the highest efficacy in BRCA mute, the very high efficacy also in the BRCA wild type HR deficient, and modest efficacy in HR proficient. So we do have option in all 3 states. So these 3 trials were then supported by 2 more trials which were presented last year. One was the Chinese study, the PRIME trial. The difference from the PRIMA trial was that here you had whole population added. In PRIMA trial, we did not allow patients who had stage 3 disease and no residual disease. They were not allowed to add the trial. Here you have them in. So when we look at and then another very different thing is that the myriad test was not performed. That's another test, a VGI test, which is done, and we really don't know what that test is, and we still need to see the validation of that test. But if you look at the intention to treat, a clear benefit, if you divide them into BRCA, germline BRCA mute or non-germline BRCA mute, there is no issue there, and these are all population, including HRP. And when they did this VGI test, a non-germline BRCA, and in the non-germline BRCA, look at the HRD and HRP, you don't see any difference, highly significant, which is very much different than what we have seen in all others. But here you see a very clear benefit in both. And then in last ASCO, we saw Dr. Monk presenting the data of Athena Part 1, or Athena Mono, which is the first 2 arms which were presented, again proving what we have seen in Prima trial, what we have seen in Prime trial, and now Athena Mono, the similar results in the whole population of HRD. That's first endpoint, very clear efficacy, and we look at the intention to treat, again you see a huge benefit with a hazard ratio of 0.52. And when you divide them in the same way with BRCA mute and BRCA wild type HRD and HRP, you see the highest efficacy in BRCA mute and quite modest nice efficacy also in HRD negative. So you have now 3 trials, Prima, Prime, and Athena Mono, answering the same question, that when it comes to we are always discussed what we are going to do with the HRP population, that's the proficient or HRD negative population, and here you can see that there is efficacy of PARP inhibitors. So after these 2 new trials came in, I started thinking about what we have answered on top of the 3 trials we had. So is addition of bevacizumab to PARP inhibitor beneficial? We still don't know. Why? Because we are missing the 3rd arm in the trials, and the 3rd arm should have been, let's say in Paula, an arm should have been that it should be PARP alone. We don't have that arm, so if you look at the level 1 evidence, we are missing that. Still that evidence. When it comes to in the BRCA wild type efficacy of PARP in R0, which was not in Prima, in stage 3, we see that we have answered that question from Prime and Athena. And if it is efficacy of PARP in HR proficient disease, again, we have answered that question also in this. Another question we have, I think one of the major questions we have, if we are going, how to tease out who is HR deficient and who is HR proficient. None of these tests we have performed in these trials are, I would say, state of the art. The best what we are using is HRD, but that's not good enough. It's a continuum. You have a cutoff of 42. My provocative question will be, if a patient has an HRD answer of 45 and the other one at 40, you're going to treat the one with 45 and not treat the one with 40 if you say that you're not going to treat patient with HRD. So I think we are not there yet, and this is what we need to work, and we are working. We have Paula data, biological material, and we are in Europe trying to produce new tests, academic tests, which will help us improve it. I think the last thing I would like to say is the safety. We have quite nice results of the safety. PARPs are given in 2 or 3 years, and you can see that the dose discontinuation is low. It's between 5% and 20%, which is quite low, 20% for Paula because bevacizumab is added to that. Even more, now we have long-term data, at least from the first 3 trials, about MDS and AML, and you would appreciate how low is the risk of MDS and AML in these cases. So the takeaways from me for the last 2 seconds would be integration of PARP inhibitors has an unprecedented improvement in our patients, and use of PARP inhibitors in frontline therapy leads to significant benefit. of both progression-free, especially in BRCA-mute patients, and some the HRD-positive patients. Testing for BRCA and HRD should be performed standard of care. So what we do is we do not take a decision on any maintenance therapy before we have results of BRCA testing and HRD testing, especially because should you start a bevacizumab? Of course, if there is a huge tumor burden, we start on bevacizumab while we are doing. Otherwise, we wait and take a decision after we have this molecular classification available. So last slide is most, if not all, I would say all patients should be considered for maintenance therapy with PARP inhibitors, bevacizumab, or both. Thank you.
Thank you so much, Mansoor. So I think just sort of that was a great summary of our upfront data, and just sort of bringing it back to our initial cases, I think we would say that patients who have a BRCA mutation in the upfront setting, you really have to consider them for PARP inhibitor maintenance in the frontline setting. This is a potential opportunity for long-term benefit. And then for patients who have HR proficient disease, we are thinking about bevacizumab, we're thinking about PARP inhibitor, but the combination of both in the PALO-1 study does not look like it shows benefit. And so patients with HR proficient disease, doing a doublet of bevacizumab plus a PARP inhibitor is potentially not going to be beneficial. You took more than 8 minutes and 2 seconds.
That was a long 2 seconds.
So we're just going to move on to our next module.
You can deduct it from Amit's.
And this will be about PARP inhibitors in relapsed or refractory disease. We have 2 cases here as well.
The next case was presented by Dr. John Chan, a 65-year-old woman treated originally in 2013 with IV and IP chemotherapy after an R0 resection of stage 3 disease. Several months later, she presented with an umbilical mass.
You can see, this is her peri-umbilical disease on the CT scan. And this is where the needle went in and biopsied that peri-umbilical lesion. She went on trial with maintenance niraparib. And this is the NOVA trial. And basically was continued on treatment with no evidence of disease for about 5 years. And despite us encouraging her to get off the treatment, she wanted to continue the treatment and went from, 3 pills to 2 pills, then ultimately to 1 pill a day maintenance. And then we finally encouraged her to stop after about 7 years.
Wow.
So is recurrent ovarian cancer curable? It sure seems like this in this case, right? And as we all have been very disappointed with this FDA retraction of some of the uses of this PARP inhibitor. This patient would not have had access to this drug today. How do we learn from this patient?
We're curious about the faculty's perspective on Dr. Chan's question about the rationale for the FDA retraction of several approvals in the recurrent metastatic setting, and also how the faculty is currently approaching the use of PARP inhibitors in this clinical scenario.
So I know everybody has a lot to say about the FDA retraction, so I'm going to ask you to keep your remarks brief. Dr. Mirza.
Thank you. I'm fortunate that my authorities are much more pragmatic than FDA. European Medicines Agency, we had the SAG meeting with them, like ODAC, and they completely agreed not to change anything, continue with how we are treating with, our patients, and we are privileged to treat our patients with PARP inhibitors. That's the short answer. I think that problem lies on this side of the pond, so you should ask.
Yes, so now I'm going to ask my colleague, Dr. Penson, who is in the US, your thoughts.
Sure. So we actually saw some of that with the PAOLA-1 data, so that the flip of those curves and the overall survival and adverse hazard ratio of 1.19. And so the all 3 companies, Clovis, GlaxoSmithKline and AstraZeneca, voluntarily withdrew it because the hazard ratio for 2+ or 3+ lines for olaparib was 1.3, and it was staggeringly consistent. So I think it is a signal, and the FDA's mandate is to protect Americans, not Europeans.
Joyce?
And it took me 22 years to become an American. God bless America. So. But so we have to be concerned about it. We have to talk to patients about it. It has to be a patient-centered decision, but it is not an easy discussion. 1.1% risk of AML. It's, Solo 2 is heading to 10% risk. It was reported as 8. So, we have to be concerned.
Mansoor, I would love to come back to you, but I'm going to go to our neutral Canadian party.
It's always good to be neutral and Canadian. So I think this is a really, really challenging situation, to be honest, and I don't think that we've really got very good data. Part of this, and I'll cover a little bit of this in my talk, but I think clearly the question is, does a second-line PARP inhibitor really improve the outcome in some patients? And similar to Dr. Chan, I have a patient who was treated with recurrent disease as primary therapy and went on a PARP inhibitor for 12 years in a setting which previously we would have said is incurable. And after 12 years, she came off the treatment and is still off treatment a few years later. So I think we have to sort of really look at this in terms of aggregate data and what is the data showing us. I think some of the sort of concern is that the survival endpoints that are actually being used were not necessarily the regulatory endpoints. But the question is, are we actually seeing a little bit of a signal that post-PARP inhibitor, perhaps there is an increase in resistance, and that may make it more challenging to overcome with chemotherapy? And so I think we need to sort of be concerned about the data, but at the moment, I would still really individualize the decisions based on patients. And generally, as recurrent ovarian cancer is not curable, in a patient who has never seen a PARP inhibitor, if there is the potential to use that in that setting, with due discussion, I would still consider that. And that's the approach that we're sort of currently taking in Canada.
And that's why you're a balanced northern neighbor.
Yeah, exactly.
So I think, as we've heard, anecdotes are not data.
Yeah.
Overall survival endpoints were not, they were not the analytical endpoints of these trials. These, I think, are hypothesis generating, asking questions that we have to answer so we can do the best job for our patients.
I think we need to sort of really look at this and actually see what data we need to gather in an appropriate manner so that we don't actually react too quickly to data that's still relatively nascent, and try and get a balanced view.
All right. We are going to move on to our next case. I'm sure all of us have many things to say, Mansoor, and you can find us after this session to ask us more.
The next case was presented by Dr. Thomas Morrissey, a 51-year-old woman with a germline BRCA2 mutation who was initially treated in 2010 for stage 3 disease with surgery followed by carboplatin paclitaxel, but some years later was found to have a new isolated mass near the cecum that was removed and proved to be a recurrence.
Since there had been a long interval between disease-free interval, it would elected to treat again with paclitaxel carboplatin, but added bevacizumab this time for the 6 cycles. After the 6 cycles, the CA-125 normalized, but on CAT scans, there was some nodules noted in the peritoneum and a few enlarged lymph nodes in the periaortic area and mediastinal areas. We decided to place the patient on olaparib and bevacizumab maintenance, which she's responded absolutely beautifully to. She's been on that treatment for 19 months now, with following CT scans every 3 months since the CA-125 is normal. And the lymphatic disease has been shrinking with each CAT scan. So the question is how long? So the patient obviously is worried. This is recurrent disease, generally not often cured. And this medicine seems to be working very well. And she's very reluctant to stop the olaparib, even though we're nearing kind of the 2-year mark, which is where we usually think about stopping things based on the data that we have and the risk possibly of myelodysplasia and other side effects.
Like many patients, this woman is reluctant to discontinue the PARP inhibitor, but Dr. Morrissey also has concerns about long-term toxicity. Your thoughts on this will be appreciated, along with your usual approach to treatment duration with PARP inhibitor maintenance, either in the primary or recurrent disease setting. An additional query is the question of whether tumor-informed cell-free DNA has been useful in determining treatment duration of PARP inhibitors in ovarian cancer.
So we have limited time, so this is going to be rapid-fire answers. Dr. Dr. Penson, in recurrent platinum-sensitive ovarian cancer, where the trials were forever, do you stop maintenance early and when?
So it's really only olaparib and only in BRCA mutant positive patients for 2 years. Even though SOLO2 was treatment to progression, I've backed off to treating for 2 years, given the impressive data for 2 years upfront. The ctDNA data, we presented this from Olympiad and SOLO3 at ASCO last year. And breast cancer patients have twice as much circulating tumor DNA. So we actually use a tissue assay to look for reversion mutations, which are quite easy to find.
Dr. Raza, is that what you're doing?
Well, first of all, I would have asked my gynae surgeons to evaluate this patient at the time of relapse if patient can have secondary cytoreductive surgery. I didn't hear that. Probably it was discussed. And I would treat that patient with carboplatin paclitaxel. Regarding bevacizumab, again, that was not a bulky disease. That was not a huge disease. So I would have waited for bevacizumab and started this patient on PARP inhibitor. This is extremely platinum sensitive patient, and I would have given PARP inhibitor alone, 0, okay.
We're at time though, but how long? Would you go indefinitely or would
we cannot translate the data from PAOLA-1 to relapse disease. We have no data to stop treatment. On the other hand, we know that longer we give the treatment, probably we are making these patients not only PARP resistant, but also platinum resistant. We don't know yet. We have to look at that in more detail. And second thing, we are increasing the risk of MDS-AML. So I would not stop. I will take the discussion with patient and be careful, but I will continue the treatment.
Great. And Dr. Raza, you're speaking next, so you'll get the final word.
So final word on the last one. I agree that I would probably continue treatment and have the discussion in terms of the risks rising over time, but I would not preemptively stop at 2 years. We do look at circulating DNA, but to be honest, at the moment, it's not at the level that we can actually base decisions on that, and sometimes you get false negatives as well. So it's an open question.
All right.
Okay. I'm going to talk about PARP inhibitors for relapsed refractory ovarian cancer over the next 8 minutes. These slides are, I'm told, on your iPad, so that if I start running out of time, please feel free to have a look at them. So the PARP inhibitor story has been evolving over the last 14, 15 years, and I think, as you've heard, amazing activity, really, really active as a single agent initially, and maintenance strategies have been very, very effective. And I think that the data is actually telling us that earlier use of PARP inhibitors is better, and in that setting, you can give it for a shorter duration, and potentially we're beginning to see tantalizing improvement in survival as well, and potentially synergy or additive effects with anti-angiogenics. The treatment question I'll come back to. The scene has changed quite significantly so that we're now using and integrating validated biomarkers, and activity does go beyond BRCA and beyond HRD. But I think that there has been a little bit of a concern in terms of how do we use it in a recurrent setting. So just in terms of context, I think it's important to think about how do we use PARP inhibitors, and we're really using them in 2 different settings. One, which is the most common, is a maintenance setting, where you give chemotherapy and then you maintain that chemotherapy benefit, and sometimes there's a bit of additional benefit, but use it in a maintenance setting. And many of the studies listed on the right-hand side have actually used it in this pattern. The other setting, which is really where we started, is using it in a relapse setting as a single agent, where it's actually used as a primary treatment. And several of the studies really looked at this setting in terms of initially looking at the activity, and went on to sort of say, could you actually have a chemotherapy-free setting in which you use PARP inhibitors? And that's where there's been a little bit of a wobble. So really, I borrowed this slide from Rob Coleman, who used it earlier this year, that there has been a bit of a wobble, that there have been sort of in the FDA withdrawals with multiple indications, as you heard about in one of the questions. And what is the sort of, how do we start interpreting this data, and what should we be doing in terms of navigating this in a real world setting? ASCO also published some guidelines, and again, there's been a sort of a decent amount of controversy in terms of the guidelines, which I've sort of reproduced here. The main recommendation from ASCO was that PARP monotherapy maintenance may be offered to patients with epithelial ovarian cancer who have not already received a PARP inhibitor and who have responded to platinum-based therapy. And for that, the evidence is high. But there's a caveat that's added to it, that maintenance therapy with niraparib for patients without germline mutations should really weigh potential progression-free survival benefits against possible overall survival decrement. And there, the strength of evidence is cited as low, and the recommendation is moderate. So there's weak evidence, but it's an early signal. There was also two additional sort of recommendations that monotherapy should not be routinely offered to patients for the treatment of recurrent ovarian, platinum-sensitive ovarian cancer. And this is where there's intermediate quality of evidence, and the strength of recommendation was moderate. And again, we'll talk a little bit about this in terms of the settings where it has been considered and where perhaps there may be a bit of a shift. And then the third recommendation, which is where there's stronger evidence, that monotherapy should not be recommended for patients who really have platinum-resistant recurrent disease. So if you have resistant disease, in that setting, the likelihood of benefit is low, and there the evidence is strong. So how has this suddenly changed? And if you sort of think about how PARP inhibitors were developed over the last 15 years, really there have been three different settings. The initial studies really focused on phase 1, phase 2, and phase 3 studies, looking at activity as treatment primarily, and there were multiple studies that were done right from the initial stage to try and look at this. We shifted to maintenance therapy first in a recurrent setting and then into a frontline setting, and over that shift, it really demonstrated that maintenance therapy does improve outcome in patients with ovarian cancer. And then going into the frontline setting, there is the opportunity to actually reduce the length of time that patients are on maintenance. And in that setting, there also seemed to be evidence in terms of improving overall survival. So let's talk for a few minutes in terms of what does the sort of recurrent setting look like. So what did we learn from single-agent studies in non-mutated BRCA patients? And there were sort of three different sets of studies that were done. And the first study was study 20, done in Canada, which showed that the activity extended beyond BRCA mutations. The Ariel 2 study showed the same thing and showed that in the setting of HRD, patients benefit less than patients with BRCA mutations, and patients who do not have HRD still seem to get some benefit. The Quadra study on the right-hand side, again, laid this in context of platinum-resistant disease, and patients with platinum-resistant disease benefit less than patients who have platinum-sensitive disease. But really, the activity actually set the scene for allowing biomarkers to be developed, as well as setting the scene in terms of the level of activity based on the biomarkers. It also allowed us to identify that reversion mutations really have an important role to play in terms of resistance, and this makes it very difficult for patients to respond. And so patients with reversion mutations, if they develop resistance, then those are the patients who would not benefit. More recently, the Ariel 4 study really looked at patients who had germline BRCA mutations and were really randomized between standard of care, which was chemotherapy, versus single-agent rucaparib. And the standard of care for fully platinum-sensitive patients was platinum-based combination. And for patients who were resistant or partially platinum-sensitive, they were offered weekly paclitaxel. What is important to know is that in this study, there was a crossover allowed, and a significant proportion of the patients, almost 70% of the patients, crossed over. And this really affected the interpretation of the results. The primary endpoint, progression-free survival, was met in the intent-to-treat population, and overall, the progression-free survival seemed to tell a story that in terms of delaying progression, there was an important effect. Patients with BRCA mutations, in fact, did not benefit from rucaparib and benefited better with chemotherapy. The important result, which has really challenged our thinking, is that in the intent-to-treat population, patients who were on chemotherapy had an intent-to-treat outcome which was better than patients who were treated with rucaparib. And when you look at these results a little bit further, it's important to recognize that most of the time this is being driven by platinum-resistant disease. But the interpretation of the data was also sort of confounded by the fact that there was a significant amount of crossover, but there was also a proportion of patients who were on rucaparib who did not receive any type of treatment after coming off, and it's important to question why. In terms of maintenance therapy following recurrence, there have been 3 other studies. The SOLO-2 study really showed that in patients with BRCA mutations or somatic BRCA mutations, there was a significant impact in terms of overall survival. And even though the statistical significance is just at the borderline, the median overall survival was improved by 12.9 months with maintenance olaparib over placebo. So this was an important signal in patients who have BRCA mutations. Let's shift to the NOVA study, which really looked at patients with BRCA mutations as well as patients who have non-BRCA mutations. And this is an important setting, which the FDA has been sort of really looking at. So if you look at the left-hand survival curve, it showed that in patients who have BRCA mutations, who had germline BRCA mutations that were identified, the overall survival maturity was 77%, and the hazard ratio is 0.85, and the niraparib curve is just above the placebo curve. And so this would match the data that was seen in the SOLO-2 study. On the right-hand side, the non-G-BRCA patients, there is a hazard ratio which is 1.06, which is what led to the concern that are the patients who were on the control arm really doing better than patients who received niraparib. This is confounded. If you look at the primary endpoints that were built in, the primary endpoints for progression-free survival was met, and PFS2 was met as well. And these showed that there was benefit consistently, but the benefit greater in the G-BRCA population. The overall survival data has to be interpreted in light of the crossover and missing data, because the overall survival was not followed in the same way. There was a lot of missing data and some crossover which may have confounded it. And the confidence intervals are wide. But again, it's beginning to perhaps identify that is there a story that patients who cross over from a PARP inhibitor perhaps have a little bit more of a challenging time. Similar story with Ariel 3. And again, I'll rush through this, but again, the same type of story that was seen in terms of the survival curves. But if you look at the exploratory analysis, in the Ariel 3, it does seem to suggest that patients who are on placebo seem to have a better progression-free survival when they had treatment after the placebo treatment, and that included crossover, but it also included chemotherapy, and the response seems to be perhaps more durable than patients who are on the rucaparib arm. So I think that we're beginning to sort of identify a story, and I know that I'm running over time as well, but it just in terms of looking at this, I direct you to perhaps look at these curves, because this is really trying to explain when we try and give an intervention, ideally what we want to see is something like A or B, where the intervention leads to an improvement in progression-free survival, which is carried through into overall survival as well. However, what we are really concerned about is if we see something like C and D, which is the intervention leads to a short-term improvement in outcome, but perhaps there's more resistance that builds up, and perhaps the subsequent treatments are less effective. So that means that the survival difference is emasculated or perhaps even goes the other way. And so I think in order to sort of try and really separate these out is going to require a lot more studies in terms of looking at overall survival as a primary outcome. And the sort of little box on the right-hand side shows that post-progression treatment has a very, very significant influence in terms of how we measure overall survival. So this has to be accounted for when we actually look at overall survival. And there's a significant overlap between platinum sensitivity resistance and PARP sensitivity and resistance. So I think that we need to sort of really learn about this. So I'm way over time, so I'm going to stop, but we can have a further discussion in a Q&A. Thank you.
Thank you. I was about to comment that we had gone over time. As you can see, all of us have a very good sense of time and many things that we wish to share. So we'll move on to our next session, which is to talk about the rationale for and available data with PARP inhibitors in combination with other anti-cancer therapies for advanced ovarian cancer. So we'll start with a couple of cases again.
The next case was presented by Dr. Dana Chase, a 23-year-old woman with shortness of breath, a 15-centimeter pelvic mass, a mental nodules, and pleural effusions. Thoracentesis confirmed low-grade serous ovarian cancer.
She continues to have reaccumulation of her pleural effusions. The question is, what's the best approach to a stage 4? This is a low-grade type. Should she get neoadjuvant based on those pleural effusions alone, or should you take her for upfront debulking? I'm curious what a low-grade serous ovarian cancer expert would say. Would you give her standard carboplatin paclitaxel, bevacizumab, an aromatase inhibitor, or some other combination of anti-hormone or anti-estrogen type of maintenance therapy? And then she was asking me if she could undergo oocyte harvesting prior to surgery or chemo. And would you advise that in a patient?
In addition to responding to Dr. Chase's many questions about this challenging situation, can you comment further on your approach to fertility preservation in women with ovarian cancer?
So we are limited on time, but this is a different sort of case of going into low-grade serous ovarian cancers, and how do we think about those biologically? Dr. Penson, sort of what would be your approach to a low-grade serous ovarian cancer with pleural effusions?
Yeah, genotyping, so that if there's a MAP kinase mutation, they actually have a better prognosis, and you might think about different therapy. But surgery is the backbone to treatment for stage 4 disease, because these were allowed in 2018. An overall survival advantage of 10 months for bevacizumab is very attractive. And I have patients with low-grade serous cancers frontline who get both bevacizumab and letrozole maintenance, just because, I can't evidence-base that, but putting the trials together with the ongoing question about maintenance letrozole versus the combination with paclitaxel, carboplatin, letrozole is a huge question.
Yeah, so as you know, the GY019 trial through the NRG is looking at giving frontline hormonal therapy versus chemotherapy followed by hormonal therapy. Dr. Ozo, Amit, thoughts on that?
So I think that just in terms of the approach to this patient, I agree that surgery is a really important consideration. The GY019 study, in terms of the randomization between chemotherapy and letrozole, I think is an important question, because I think one of the sort of challenges that we have is what is the true role of chemotherapy in low-grade serous cancer. The responses, unfortunately, are very, very modest and not really durable. And so in that setting, I think it's an important question to ask. However, the timing of asking that question would be after chemotherapy. So I think there's a primary treatment modality for a patient who is very young, has advanced low-grade serous cancer. I would be really sort of working with my gynae-onc colleagues to see if there is any opportunity to actually look at surgery in this setting, if there is a possibility. I think that in terms of treatment, I agree with Richard that the addition of bevacizumab in patients like this potentially may have a significant benefit, as well as helping control the pleural effusions.
Yeah, I think it's a great sort of question, because low-grade serous ovarian cancers are just a different, less common histology. We shouldn't think about them as the same as high grades, and understanding the biology is going to be really important. All right, we'll go on to our next case.
Dr. Schneider is also caring for a 48-year-old woman with HRD-positive, BRCA wild-type, high-grade serous ovarian cancer who participated in the first trial, a randomized phase 3 study of adjuvant carboplatin paclitaxel with and without dostarlimab during treatment, and also as maintenance, plus or minus niraparib maintenance.
She presented in 2019 with abdominal pain. Her CT scan showed significantly abnormal ovaries, carcinomatosis, capsular implants along the dome. At that time, our institution had the first trial enrolled, which is plus or minus dostarlimab and niraparib. She was genetically negative, but her tumor was HRD positive. So she went on the niraparib plus or minus dostarlimab for actually 3 years. Unfortunately, she recurred as an isolated pelvic implant. So my question is, at this point, what do we use now?
The isolated recurrence in this patient was resected, and the question is, how would you approach treatment of this HRD-positive tumor with progression on a PARP inhibitor?
So, not a straightforward case. Dr. Mirza.
So first of all, first trial allows bevacizumab. So I would have had triplet in that patient. That is bevacizumab plus niraparib plus minus dostarlimab. And that was not given to the patient. So she's bev naive. Second thing, this patient is showing us the unmet need, but we have patients who are progressing on PARP, and I would put that patient on clinical trial. We are performing clinical trial where we are looking the role of therapeutic vaccine together with immune checkpoint inhibitor and olaparib versus olaparib alone in the maintenance setting in this type of patients. So that would be my choice. Because giving the conventional chemotherapy with bevacizumab eventually, I don't think that is going to be, that would be the standard of care, but I would very much like to have her in clinical trial where she has an option to receive more than what we have.
Amit, we had to cut off your talk for time, but you had a slide on PARP after PARP. Would you like to comment on that?
Perfect question. So the OREO study looked at PARP after PARP and looked at settings like this where patients had had a prior PARP inhibitor, had it for a long time, and then they were re-challenged. It showed there was an improvement in progression-free survival, but the clinical benefit of that was actually really quite modest. So PARP after PARP in select cases may be a possibility, and I think all of us have considered it, but the benefit in the OREO study was actually really quite limited. So I think that's the setting in which we really need to do some clinical trials. And there are a lot of clinical trials that are actually being done with other agents, such as other anti-angiogenics, immunotherapy, as well as looking at checkpoint inhibitors and WEE1 inhibitors as well. So I think that there's some potential benefit in terms of combinations that we may be able to sort of extend to in the future. But at the moment, if you have the opportunity to enroll these patients into clinical trials, I think that would be really the setting. I think if there isn't a clinical trial, then in select cases, I think it's reasonable to consider whether PARP after PARP and whether the evidence of the OREO study is enough in order to put patients back on that. Most of us feel that single-agent PARP inhibitors as a second line, if patients have previously had a PARP inhibitor, the benefit is so small and so modest that perhaps we need to do something better than that.
Richard, I just wanted to ask very quickly, because this has been alluded to. I think everybody wants to get these patients on clinical trials. But the sensitivity to platinum, patients who have progressed after PARP, does that influence how you think about it?
Yeah, it does. I think this beautiful term, chemotherapy-free therapy, is really third-line therapy. That's where we're investigating it as an option. So second line, particularly oligometastatic disease, surgery, carboplatin, pegylated liposomal doxorubicin, and bevacizumab, that's associated with an overall progression-free response and quality of life advantage. So that would be my absolute go-to in somebody who hadn't previously had maintenance bevacizumab.
All right. So we're going to talk a little bit about sort of the combination for PARP inhibitors with other anti-cancer therapies for advanced ovarian cancer. As you know, there's been a long PARP inhibitor development timeline in ovarian cancer. I'm not going to spend the time to go through it, but we know there were a number of PARP inhibitor approvals, and then, as has been alluded to a number of times in the past 6 months, we've seen a withdrawal of a number of these indications. But what's the take-home of that? I think the take-home is that we know that PARP inhibitors work extremely well for certain patients, certainly those with BRCA mutations, but there are other patients in whom PARP inhibitors either do not work as well or they're not effective at all. And so this has really led to the idea of, can we make PARP inhibitors better? Can we combine them with other agents in order to enhance the activity of the PARP inhibitor or to expand sort of the spectrum of tumors in which PARP inhibitors are active? This is not going to be a comprehensive talk. We have 8 minutes. You've seen that we've been struggling for time already. But this figure is just sort of thinking about some of the big boxes of PARP inhibitor combinations, IO-based combinations, combinations with other DDR agents, induction of HR deficiency. So can we change the pathways, get these cells that are HR proficient to be HR deficient and therefore PARP inhibitor sensitive? And today I'm really going to talk about the IO-based combinations as they're starting to move forward in the front line. germline. Why would you put immunotherapy together with a PARP inhibitor? Well, we know that what PARP inhibitors do, they prevent cells from repairing their single-strand DNA breaks. Those then convert to double-strand DNA breaks. And when you do that, there's a couple of things that can happen that interact with the immune system. So first of all, in cells that are HR deficient, you can have error-prone repair, and that can lead ultimately to the more neoantigens that might be immune activating. The presence of double-strand DNA breaks means that you have increased cytosolic DNA. That then activates the STING pathway, and you can get a type 1 interferon response, again, an immune activating sort of process. And then at the same time, when you have these double-strand DNA breaks, you activate your checkpoints, so ATM, ATR, CHEK1 activation, and downstream of that, that can lead to upregulation of PD-L1. And so you can then imagine that coming in with a PD-1 or PD-L1 inhibitor could be very attractive. And we see that this happens in mouse models. Here is a mouse model where you can see in the this green line, the bright green line here, is the combination of a PD-1 inhibitor together with a PARP inhibitor, and the pink is the PARP inhibitor alone, all the way up the top, and orange is the PD-1 inhibitor alone. So you can see synergy in this BRCA mutated mouse model, and in another mouse model in the light blue, you can see that this combination of a PD-L1 inhibitor plus a PARP inhibitor, in fact, increased survival in these mouse models compared to either agent alone. What happens when we bring this into the clinic? So the initial studies of immunotherapy and PARP inhibitor combinations were done in platinum-resistant ovarian cancer. This was the Tapatio study. It's a phase 1/2 study of niraparib and pembrolizumab, 62 patients. All of these patients had acquired platinum resistance, meaning they were initially platinum sensitive and then down the road acquired platinum resistance. They were fairly heavily pretreated. And in our initial sort of look at these data in this waterfall plot, you can see that actually this seemed like it held some promise. There were about 50% of patients had at least some decrease in their tumor burden. The overall response rate was 18% with a PFS of 3.4 months. But intriguingly, in patients with tumor BRCA wild type or HR proficient tumors, the response rate was still about 19%, saying that these are patients where you would not expect PARP inhibitors to work by themselves. You wouldn't expect immune checkpoint blockade to work. And so that seemed promising. More recently, however, we've seen the results of the Moonstone trial. This is a phase 2 study combining niraparib with a PD-1 inhibitor, dostarlimab. 41 patients, also platinum-resistant ovarian cancer. They do have some differences. This is patients who could not have had a known germline BRCA mutation. And unlike the Tapatio study, these patients could have primary platinum-resistant disease and could have progressed within 3 to 6 months of their first platinum therapy. Not as heavily pretreated, 1 to 3 prior lines. Over here on the right-hand side, you can see the response rates. There were no CRs. The PRs are here in dark blue, and this is what's quite disappointing, an objective response rate of only 7.3%. The PD-L1 status was non-predictive. The median PFS was only 2.1 months. So could we make that better? Can we improve on the activity of IO plus PARP inhibitor therapy in ovarian cancers by adding a third agent? This is an interesting proof of concept study that came from the NCI. 35 patients getting olaparib and durvalumab. You can see the objective response rate, similar to what we've seen in our other trials, but this had pretreatment biopsies with paired blood samples. And in those paired blood samples, you can see the immunostimulatory cytokines are going up, as you might expect based upon the rationale that I've talked about. But interestingly, the circulating angiogenic factors were also upregulated when you gave a combination of IO plus PARP inhibitor, suggesting maybe you could bring in anti-angiogenic as your third agent, and that could be something would give us effect. Have we looked at this? So this is the OPAL study of niraparib, dostarlimab, and bevacizumab, again in platinum-resistant ovarian cancer, a phase 2 study, 41 patients, not heavily pretreated at all, 1 to 2 prior lines of therapy, 44% had had prior Bev. And while the waterfall plot for this is not too terrible, unfortunately, the objective response rate was not super exciting. It's about 18%. The PFS is 7.6 months. It's not sort of, it's fairly respectable for this population, but I think we were all really hoping for more when we think about the components of each of the components of this combination. The objective response rate was consistent across the subgroup, so HRR status was not a selection factor, neither was PD-L1 positivity in terms of prediction for response to this regimen. maybe platinum-resistant ovarian cancer is not where we should be developing IO plus PARP inhibitor combinations. So, as we move further into the earlier stages of our therapy, looking at platinum-sensitive ovarian cancer. And the Mediola trial is a very interesting trial that has looked at both the doublet and a triplet combination, olaparib, durvalumab, and bevacizumab in germline BRCA wild-type platinum-sensitive ovarian cancer. These patients, again, were not heavily pretreated, 1 to 2 prior lines of therapy. They had sequentially enrolled cohorts of triplet and doublet therapy. You can see at the bottom, the activity of the doublet therapy looks, again, quite respectable, objective response rate of 31.3%. But remember, these are platinum-sensitive ovarian cancer patients. Maybe that's not as good as chemo. But here, the triplet combination of olaparib, durvalumab, and bevacizumab, there's a confirmed objective response rate of 77.4%, a PFS of 14.7 months, and OS of 31.9 months. This waterfall plot is certainly quite tantalizing and makes us think about, where could this potentially still go? When we think about side effects of these combinations, these side effects, the profiles are very consistent with the known side effects of the single agents. If we think about the triplet therapy to the doublet therapy, we may be seeing some increased toxicity in the triplet therapy in these two trials. About 30% of patients were discontinuing at least one of the drugs due to toxicity. And that's not a surprise. You're looking at 3 agents instead of 2. Where are we going next? So what's the future of PARP inhibitor and IO combination? So we now have 4 trials that are in the frontline setting. These are phase 3 trials that are looking at different ways of combining PARP inhibitor and IO therapies. These are, we're expecting these results to come in sort of the near future. As these trials come in, I think we have to remember these are very different trials, different populations and different approaches. Athena combo is a pure maintenance trial. The first trial is a treatment trial and has investigators' choice bevacizumab, as does KeyLink 001. Duo-O and KeyLink 001, in terms of their main analyses, are both in patients with BRCA wild-type tumors. As all of this information comes in, I think we're going to have to really carefully think about it and synthesize it. These trials do have different designs, and hopefully it will give us an answer about whether or not we've got a future for PARP inhibitor and IO combinations in our frontline treatment. In summary, PARP inhibitor combinations have the potential to build upon the activity of PARP inhibitors in ovarian cancer. The PARP inhibitor and IO combinations, which was the focus of this talk, have some signals of activity in early phase 2 trials. Those signals are predominantly in the platinum-sensitive setting. There are 4 phase 3 frontline trials that have results pending. I didn't have a chance to talk about it, but there are PARP inhibitor combinations in development. There's a couple of additional slides in the slide deck that you can see some of the ones that are actively coming through in development. And so I think that there is a lot of potential here for how do we make PARP inhibitors better? And then our next question will be, as we make PARP inhibitors better, where is it that we're going to be able to apply it in which part of the ovarian cancer life cycle? Thank you so much. All right. We will now move on to our final module, which is novel agents for the treatment of ovarian cancer. And again, we're going to start with a couple of cases.
The next patient is presented by Dr. Chan, a 66-year-old woman with recurrent stage 3 ovarian cancer who participated in the INNOVATE-3 trial, which randomizes patients with platinum-resistant advanced ovarian cancer to paclitaxel alone or with tumor treating fields. The patient had a good partial response to treatment for 9 months, but experienced dermatologic toxicity.
She had some severe rash associated with the application of the adhesives around the tumor treating field. She was very compliant and very good patient. She immediately restarted after some steroid and also some cream that she applied on. And she continued to see some response associated with this combination with weekly Taxol and tumor treating field for about 9 months until she progressed. My question for the investigators is, where do they think the future of this tumor treating field in our cancer space, which is in ovarian cancer, where the disease is not just limited to one site? Some of these patients actually have pleural fusions on top of ascites with liver mets, Tumor Treating Fields targets, certain microtubules, are there any novel biomarkers that can help identify subgroups of patients that may have particular benefit?
Dr. Chan's questions reflect the considerable interest physicians have in tumor treating fields, but also many questions, including current hypotheses regarding mechanism of action and clinical experience with toxicity, particularly dermatologic, and also the question of the relationship between exposure to tumor treating fields and treatment efficacy.
All right. So full disclosure, none of us here have personally treated somebody with a tumor treating field, so that's just a full disclosure from our panel here. Knowing that, Dr. Penson, first up, what do you think about the future of tumor treating fields? Are you excited about them?
So I think, seeing what the INNOVATE-3 trial result is really interesting. And imagine it was positive. It's challenging, exactly as John says, to, sort of hone your technology to the challenges of ovarian cancer. But you can volumetrically evaluate mesothelioma on scan. And you can imagine something like IMRT. And the future, who knows, might contain sort of beads or nanobots that you direct to certain places. So, but it really makes us rethink, okay, let's be creative about how we respond to this terrible disease.
Mansoor, I know you mentioned that you'd seen somebody who had once had tumor treating fields. What do you think about the potential for
So
tox?
I think the quality of these jackets have become much better. The problem about rash has been resolved quite nicely. The batteries are now of better quality, so you don't have to go home and change the batteries, and they're lighter. So I think the patient acceptance has become much better for these treatment, TTF treatment, and I believe that once we have the phase 3 trial results available, of course this is a long way to people to take it in, but that would be a great another option for our patients.
All right, great. We'll move on to the next two cases. They're going to be grouped together.
The next two patients have recently been started on the antibody-drug conjugate mirvetuximab soravtansine, beginning with Dr. Chase's 73-year-old woman with stage 4 multiply recurrent disease.
She's interesting because she does have PD-L1 as well as folate receptor alpha positivity on the KRAS assay. When do you decide that hospice is her best option versus fourth-line treatment? Do you use immunotherapy in ovarian cancer patients with PD-L1 on profiling? Do her comorbidities concern you regarding the use of mirvetuximab? This patient, heavily pretreated, poor performance status, 73. What do you tell her in terms of tolerance? I know mirvetuximab is apparently pretty well tolerated in terms of ocular side effects and other side effects. What do you tell her is going to be her average length of therapy in terms of how many cycles do you think she'll get of mirvetuximab before she progresses?
Dr. Willmott also has a patient with multiply relapsed advanced ovarian cancer whose folate receptor alpha was positive.
What sort of strategy does your office have for partnering with eye care professionals?
There's another antibody-drug conjugate. The short name is UPRI.
Yes, we have used that drug on a trial. The one that we are currently enrolling in at my site is called Up Next. For that trial, they do have to be NaPi2b positive to enroll. Obviously, it seems that ADCs are really the next great leap that we're going to have in therapeutics for malignancies. How do you see we're going to be able to sequence these kinds of medications? I will say, thankfully, in my experience with appropriate dose reductions, these medications have been very tolerable. And I have not had to have patients come off of the medications related to toxicities with appropriate mitigation strategies or dose reduction.
These two cases raise a number of questions related to the use of antibody-drug conjugates in platinum-resistant ovarian cancer, including the approved ADC, mirvetuximab soravtansine, and others in development, including ifinatamab rilsodotin or UPRI, specifically the efficacy and tolerability of these agents, and in the case of mirvetuximab, specifically ophthalmic toxicity and how it can be prevented and managed.
All right, so there's a lot of very good questions there. So we'll start tackling them one by one. I think let's start with mirvetuximab. Amit, what's your personal clinical experience with mirvetuximab, efficacy? How do you manage the toxicities?
So I think we've had a lot of experience in terms of mirvetuximab as participating through the clinical trials. And I think that the opportunity to actually have a potentially predictive biomarker that identifies patients who are perhaps more likely to respond makes it a little bit easier in terms of the discussion. The approach that we have is, first of all, looking at every patient who has recurrent disease, particularly platinum-resistant disease, to actually have a realistic discussion in terms of the goals of therapy, including symptom control and palliation. We actually work with our palliative care team from the very get-go, so that there's a lot of evidence that if you actually start thinking about symptom control and palliation long-term, the acceptance is perhaps better, and there isn't a sudden sort of transition from one team to another in terms of palliative care. In the mirvetuximab data, again, the data looked really quite encouraging that in platinum-resistant disease in patients who previously had bevacizumab, the Soraya trial suggests that about a third of the patients will benefit. And so I think that that's actually a reasonably good indication that many patients will benefit. But again, that is in the patient population that's heavily selected, good performance status generally, and able to participate in clinical trials. If we are using agents such as mirvetuximab, then we actually have patients assessed by ophthalmology in terms of making sure that there's a baseline assessment done, and then really rigorous education and teaching in terms of eye drops and eye care from the very get-go in terms of trying to minimize the symptoms, and having a very open policy in terms of patients reporting to us if there are any concerns early in order to sort of navigate those. But I think the antibody-drug conjugate area is actually growing. There's a lot of studies in this space. Many of them have a similar sort of class effect in terms of eye toxicity. Some of the newer ones perhaps less so. And I think we need to sort of start integrating these into our sort of sequence of treatments, particularly if there is a likelihood that there's a significant benefit for the patients.
Fantastic. Mansoor, you had a comment?
Just a few, great. Just a few things I would like to say, because there was discussion about UPRI and MIRVA. I would say that if you look at that testing, there is a very little overlap. First of all, for MIRVA, you need to have folate receptor alpha high, not just positive, to treat. And there is about 20% overlap. So you have both options for our patients available. Second thing, I think that we have learned the hard way that we thought that when we will bring the drug in, we would be doing that. No, the testing was a great issue, and that has to be. So we have to really work hard to get the whole setup ready before you go ahead, and that's the same for the ophthalmologist and everything else. So I think, and the third thing is when we are doing the early trials to see the drug development, the dosages of the drug, ADCs especially, we cannot reduce the dose with huge steps, because there is, the efficacy goes down. So we have to really find out the real dose, and it would be best if we find out before we get approval from FDA to do that, and not go back and do these experiments. So these are the things I just want to point out. But ADCs are the agents which are next to PARP in ovarian cancer.
Yes, they are the next exciting sort of class of agents. I think that one thing I just wanted to comment on is, for dose optimization, of course, here in the US, there's sort of Project Optimus that is a very big part of drug development. And with eye toxicities, I think we've said ophthalmologists, but for people who are practically thinking about sort of using mirvetuximab or tisotumab, we are able to use optometrists for those exams. And so don't feel like you are sort of handcuffed to that. Richard, I'm going to ask you about upafitamab, and just keep in mind that your answer is going to take into your time of your discussion.
13 seconds.
So go.
So fourth-line therapy, I think my favorite question is, what care do you want at the end of your life? lot of patients think of it as theoretical, so they, at least they give you an answer and you can come back at them with that later. And an audit at MGH of patients who get immunotherapy as late-line therapy in hospital, half of them died in hospital. So you have to be careful about using it as magic. So it's my privilege to talk about novel agents. And so great stories in ovarian cancer. Platinum, the discovery of agents like paclitaxel, the insight about antivascular and anti-angiogenic therapies. This is bevacizumab. And then following the science, this is olaparib in the enzymatic cleft of poly-ADP ribose polymerase. And so we're going to talk about two antibody-drug conjugates. That is exactly as somebody said, like the next frontier, and touch on tumor treating fields and some of the new strategies. So antibody-drug conjugates, great mechanism of action, a tailored approach to unique molecules. This is mirvetuximab with the antibody, sort of a DM4 toxic payload, and that binds into the cell at the folate receptor, internalizes, lysosomally degrades the payload, which is released and can hit associated cells, a bystander killing to kill cells. So it's an exciting agent, and there's real challenge with evaluating the folate receptor alpha. It really derailed the forward studies. So it is a folate transport that is upregulated in ovarian, endometrial, triple-negative breast cancer. The majority of patients have some expression, and folate receptor high expression, about a third of patients. And there is a differential to normal tissues. So you can use archive, old tissue, and fresh biopsy, and it seems to be pretty similar. It doesn't change much over time. It's evaluated by the +1 to 3 and percentage evaluation. So the SORAYA study, fabulous study, enrolled 106 patients, platinum-resistant disease. More than a third had stage 4 disease. More than a third had 0 to 4 month platinum-free interval, but that wasn't allowed when you were first-line platinum-resistant. 48% prior PARPs, all prior BEV, and 51%, more than half the patients had 3 prior lines, dosed at 6 milligrams per kilogram, the ideal body weight you have to be cognizant of, and objective response rate, the primary endpoint. So in that study, the objective response rate was 32% of those 106, 34 responders, 5 complete responses, 29 partial responses, and this is the swim lane plot, with the dots being first response and the beige bars complete responses. And this was durable and beneficial in terms of patients. So the waterfall plot, really nice disease control rate in 51%, tumor reduction 71%, median progression-free survival 4.3, and actually with Rob's update yesterday, median overall survival up from 13.8 to 15 months. And the toxicity that people know about, blurred vision in about half the patients, and you really have to sort of anticipate it. It typically kicks in cycle 2, and there's a lot of intervention to prevent it. So ophthalmic exam, topical steroids 6 times a day out to the 4th day afterwards, and then 4 times a day, lubricating drops after your steroid drops indefinitely. And then manageable and reversible. It really does reverse in patients. And less than 1%, one patient in this trial actually got discontinued for eye toxicity. And the upcoming study is really exciting. Mirasol is the one we're waiting for. That has completed enrollment. That's investigator choice versus mirvetuximab, just high expressors. And then platinum-sensitive disease, 3rd plus line, that chemo-free option, that's a completed enrollment. And then the maintenance therapy. You get platinum-sensitive disease, you finish the mirvetux carboplatin, and then get mirvetux maintenance, or a really nice trial, the Gloriosa trial, in which you do maintenance. You either do mirvetuximab BEV, 39% response rate in the phase 2, or BEV maintenance. That's actively enrolling as well. And so UpRi, which is not the proprietary name for upifitamab rilsodotin, this is different. This is an anti-NaPi2b, and in this, there's not one toxic payload. 10 to 15 is the drug antibody ratio, the DAR. And so that actually comes from this mollusk and works in a very different way. And Masana have a proprietary linker. The $lock is a controlled bystander. So the red blocks are where it's locked into the cells, and then as the hydroxypropylamide gets cleaved off, it becomes more ionized and gets locked into those cells. So you don't damage other cells, is the theory. About 2/3, in contrast to folate receptor alpha of high-grade serous ovarian cancer, express the NaPi2b target, and it's the same system essentially in evaluating. And the phase 1 clinical trial evaluated, and then the 42 milligram per meter squared dose was a little toxic, and 36 is the declared winner. And you can see from this chart here, I'm not sure I can point very easily, but fatigue, LFT abnormalities, thrombocytopenia, and anemia were really the differentials. And so 36 milligrams per meter squared is the phase 2 dosing. And in that, in the patients with NaPi2b high, the response rate was 44%, which is really quite attractive. And there's ongoing trials, the ENGOT trial of the phase 2, that's a platinum-resistant registration trial. The phase 3, which is you get platinum-sensitive treatment, and then you get either maintenance UpRi or placebo, a nice way to really sort of follow up an accelerated approval. And then an expansion cohort looking at carbo UpRi together, followed by an expansion of that once the phase 2 dose is established. So ADCs, at least 10 approved, so it's not like ovarian cancer story, but we're excited to join that. And then treatment, tumor treating fields, TTFs, these are illustrated here. You literally put these coils on a patient and treat them for most of the day, and they disrupt microtubule and chromosomal assembly. And there's a complicated mechanism of action. So DNA damage response downregulation, interference with cellular mobility and migration, increase in vascular permeability, disruption of mitoses, and enhanced anti-tumor immunity. And so if you increase the intensity, that sort of like frightening hum, there's more effect. But actually the frequency of that electromagnetic field, there seems to be a particular sensitivity of tumor cells to the 200 kilohertz, and so that's what's used. You see the CI in the middle of the screen. So for different cell lines, when you give it with paclitaxel, when the CI is less than 1, that suggests synergy. So I don't know whether this is really additive or synergistic, but there seems to be an interaction with paclitaxel which has been exploited. So in the phase 2 clinical trial, Ignace's clinical trial, this was done with weekly paclitaxel, 31 participants. Objective response rate was 25%, median progression-free survival just under 9 months, and clinical benefit in 71, and 61% of patients alive at 1 year. 84% of people got burns with tumor treating field-related dermatitis. So the Innovate-3 is ongoing. This is expected to report relatively soon, 540 participants, paclitaxel with or without tumor treating fields. And so my less than a minute, the PARP inhibitors have been really fabulous. And so reversion mutations, but other mechanisms and other interactions are important. And then adding immunotherapy. Joyce talked about this, but the whole mechanisms in terms of how that interaction happens is exciting. The ADCs, there are a lot of ADCs in development. And then targeting DNA damage response and P53, some of the new things like stabilizing P53 with small molecules, anti-angiogenics, and so putting it all together. How do you put it all together, and how do you see the things that you don't see? So like every tumor board we hear about Pax8, it's a fabulous target and really hasn't been exploited. And I want to finish with a comment about CA125, which is a fabulous target. So CA125, or MUC16, a glycoprotein protein in the surface of cells, and really defines 4 seasons. So for patients, the hope of cure, the hope for remission, the hope of quantity of life, and the hope of quality. And so Regeneron has this really nice program in which it targets PD-1 with cemiplimab, and then activates the co-stimulatory factors. Once the immune system's in gear, adding gas with their antibody 5668, and actually putting these antibodies together, inducing with ubamatamab, and amplifying with 5668. And so this is a patient of mine, had bulky disease, you can see her disease here, and had a complete response that was really sustained. And then, like my 12-year survivor, who died of head and neck cancer after 20 years of ovarian cancer, 12 years of PARP inhibitor, from Doxil, from pegylated liposomal doxorubicin. This lady got lung cancer. So it's like, living with cancer is tough. But thank you. The future is exciting.
So thank you very much, and thank you to all of you for coming and spending your lunch with us. We really appreciate it. Thank you to our online audience. And then I also wanted to thank all of our community-based oncologists for participating and bringing us cases and questions today.